Y'all ready to learn about mandibular flexure?
Yes, let's learn about mandibular flexure.
Good. Love the excitement. So when Liza and I were looking at mandibular flexure, found a handful of literature, a good amount, but what we were really focusing on was how mandibular flexure ties in with implants, specifically full arch implants. We did also use some literature that was kind of more geared towards onesies, twosies, just to kind of get the overall picture. Looking at big picture level, we realized there were quite a few questions all over the place, but really put them in a few more concrete buckets. Those being, okay, we need to know what mandibular flexure is. Once we know what it is, we need to know why our clients need to care about this. And we realized part of why they need to care about this is for two things. First one, it really impacts their clinical planning, surgical planning, restoration design. So we needed to be able to concretely say, hey, this is the clinical implications of mandibular flexure, as well as what is the tie between mandibular flexure, photogrammetry / just digital records. That was the big picture that we looked at. So as we broke through the some literature reviews, some studies, one meta-analysis, we were looking at really those key points that we can pull out and be like, hey, that's a super quote, that's a great nugget, let's use it, that has a reference, and build those slides. From those slides, those kind of nuggets that we looked at, the big picture that we found was the number you'll see and hear over and over again is at 20 degrees. Mandibular flexure doesn't really super kick in until we're opening the jaws from that 0 to 20 degrees. Once we hit that 20 degrees, that's really where that notable flexure is. It can be anywhere from a few microns to a millimeter. That's a huge variation. And what we found was if you're keeping it under that 20 degrees, that flexure isn't really playing into it. Well, when do we see that above 20 degrees? Sticking the intraoral scanner into the mouth and taking records. Well, is the mouth always open when you have that restoration seated? No. So the flexure of the jaw is different when you're capturing the measurement with the intraoral scanner versus when you're actually seeing that restoration. But thank goodness for literature that has actually already written, taking digital records severely takes that out of the tolerance stacking consideration, especially if you're using, say, photogrammetry with really small targets that don't require them to be open above that 20 degrees. So we know that's important. We know why our clinicians should be worried about it. Our biggest thing is how do we get the messaging across? Be like, hey, this is something you should consider. Great feedback that we got from Gareth and Rachel was this is not necessarily a standalone point. How, like, let's say our IK bodies being titanium. That's a great standalone point. That is something that doctors are like, yes, this is important. Mandibular flexure is one of those things that kind of goes in as a sub-point. Like, yes, it's important. Not going to be a buying point. But when you're looking at mandibular flexure, when you have those people that are like, okay, what is it? Liza found a phenomenal graphic that really shows how those different muscles play. So if you want to kind of talk to like how those are pulling.
So this is a graphic that I took a picture of from the book, The Evolution of the Human Head by Daniel Goleman. And it shows the different areas of flexure. So not only do you have the flexure left and right, you've got flexure buccal linguals, and you've got expansion upon bite force. So this shows the flexure you have in demand.
When you bite, also.
Yes.
When you bite, there's another, there's again a
Yes.
deformation.
Mm-hmm.
So actually, okay, so it's really complicated because we measure in a situation where we don't have forces.
Yes.
We measure with interest in a where we have too far open, basically,
Yes.
and a completely different deformation. Then we insert it in some situation, and then we bite again in different situations. We bite to have something
You
else.
don't take into account the mandibular flexure, so then you have the occlusion is not matching up there, where it's putting more strain and increasing the flexure, and then you run the risk of failing the implants, the prosthesis, and long-term failure of.
So if we measure with the impact of mandibular flexure, the jaw will be in the wrong position basically when we start to bite.
Whereas you can reduce that factor by keeping the bite open and creating fewer prostheses by using the ICAM, because you use all the ICAM bodies, and you can use that extra more.
20 millimeters, that's 20 degrees, you see what does the from the mouth. That's like this here.
A little more. Yeah.
Well, there's other people that can't
that's-
put stress on the condyle,
Right.
Yeah.
and so the condyles go out of position.
Yeah. You can feel it actually.
Yeah, you can.
It starts to move out, and when it moves out, you can assume that something here changes.
Yes.
You also have the masseter muscle, which is constantly pulling. So the wider you open, the more that muscle is pulling on your lower jaw. Therefore, it's flexing in this way as well. So not only this way, but this way.
So this is a muscle down here that pulls it down.
No, well,
No, it's here.
How does that pull it down?
Because this is a very strong muscle in your face. It can cause, if people have severe clenching, it can cause.
I get Botox.
Notching, which actually gives you like bony points. It changes the lower structure of the jaw, so that muscle is strong enough.
Tora.
It's strong enough to just change the whole lower jaw. Therefore,
But that's used to bite that muscle.
it's used to open.
Right there, but it's actually.
How can muscle open? I saw the Canadian
Yes,
contract.
there.
Well, I mean, it changes when you open.
Oh yeah.
Yeah.
Stretch.
So
Eccentric.
then that's pulling your jaw.
Also helps it that when you open your jaw, it's not just falling. That it kind of stays bouncing.
The lateral
Yeah.
pterygoid
Yes.
as well. That it's also creating strain. I think there might be one picture on that as well.
Yeah.
That has like it's very small.
Yeah. And so if there are any of these pieces that you're really like, okay, you know what, that's something that we can type something else. Each slide has a different article page, but this one we found, this was a meta-analysis we found very impactful just because it had a great synopsis of, here is mandibular flexure. It is a thing. You should care about it. And these are clinical reasons why. Looking at not just is it, hey, the jaw is moving itself, but if you have implants already placed in and that flexure is happening, that the implants can also total a little bit. So it's not adjusting all proportionally, but each different implant could have different levels of strain on it. So it could be turning, could have stress between these two versus these two, and at least the longevity kind of impacted.
It's creating a cantilever effect.
Yeah.
It's flexing because you don't know the right position, so you get it like here. It's moving because prosthesis does not have a passive bed. Then that's moving, maybe moving itself out of the home, so then it's going to lead to any other implant to eventually move great prosthesis and failure.
So that's an extremely interesting observation you just made. Because basically, when you open it, it's not just going like this, it's actually changing the angle. Which means if we have now a cam body attached to it, that's kind of what it looks like this. So we basically get a fundamentally wrong direction of the implant. Because it should be like this, and actually we get an angle like this. That will introduce tremendous stress on the structure.
Especially if it's inner oral
Yeah.
versus.
Yeah.
I just did a scan on the patient, the same patient before. I just did a scan on her, and I had her sit as small as she could, and just had the assistant pull the lip out of the way, and she was over that,
Yeah.
and I was able to get 2 scans back to back. Actually, I think I got 4. I got 2 with the Gen 3 and 2 with the Gen 5. So it's totally accomplishable to not have them open as much with the ICAM because the way the light is structured is not specific.
I think you try to do measurements and when they open and compare the data.
No, but Dr. Stevens suggested I do that except to prove that this is important. I should do 3 scans.
Yeah.
So one with maximum opening, one
One in between. Yeah, that would be extremely interesting to see because that would basically prove the point. Yeah.
Yeah, he suggested doing that data with the CBCT and like overlaying it, and I'm maybe not smart enough for that job. But
No, you're smart.
yeah, you're definitely smart enough.
Yeah.
But,
If somebody's
Just
smart
gotta
enough
take
for the
the
job,
measures.
it's-
well, I mean, I meant the overlaying part, finding the discrepancies. But
This is great stuff, Aya.
Yeah.
Thank you,
Absolutely.
guys. This is very good.
Well, and kind of our biggest questions for y'all is better ways to phrase it. Also, when talking to doctors, we and I had a great suggestion of when talking to clinicians about kind of more their practice management, their planning of asking them not necessarily like, hey, have you seen flexure be an issue? But what things do you take into consideration when you're capturing your initial records? What things do you take into consideration when you're planning? Seeing if they can almost lead themselves out of like, well, I do consider will the RC or the job be moving? What things happen? Be like, well, actually, there's ways to counteract that. And then this was, I think, a little biased. Our favorite article that was told us, hey, digital impressions, that is definitely a way to get that out of that tolerance stacking error out of, to really look at. That'll help you not have to factor that into your surgical planning.
Can you repeat that, like the key takeaway that you got from that article again?
Yeah, absolutely. The key takeaway from this one that we loved was that we were able to see that someone else had gone in and done the research and was able to say, use digital records. The analog, the conventional, that's not going to help you when it comes to adjusting for mandibular flexure, but digital records can take that off your plate of something to worry about when it comes to really that error stacking from that aspect.
but only if you can take them and jump.
There you go. Yes.
Correct. And another phenomenal thing that Liza brought up earlier was not just looking at, hey, digital records, great, photogrammetry, great. Looking at the specific types of scan bodies that photogrammetry devices are using. There's a reason ours is so small. There's a reason that it's the shape it is. If the targets are super large and you're forcing the mouth to be even further open, then it kind of negates the benefit.
the horizontal scan bodies are going to be impossible.
Yeah.
Reduce that, and then also you're going to have what Rob and I discussed is the tongue. The tongue is the strongest muscle in the mouth or the head, I think. But that's going to be pushing. It's going to be fighting. Therefore, you're introducing mandibular flexure right there.
How many groups?
Can we say
When
more
the
about
tongue
that?
pushes against the scan body, it will basically also lead to deformation.
Yeah.
Well, not just pushing,
Yeah.
Besides
pulling on the
moving
other
the
side.
Yeah.
scan body, okay.
The other thing to consider
Yeah.
is a lot of the reasons why people are getting the implants in the first place. The actual,
Three.
whatever, somebody help me,
That one, yes.
yeah.
This one. It says flexure is more pronounced in edentulous patients, and I guess since I've seen some cases, you have to imagine why that patient is edentulous in the first place. So they've got something more than cavities or just poor mouth care. There is obviously a bite force,
Bruxism.
something that is causing them to be edentulous. Therefore, if you don't have the proper implant placement, that patient is going to be more at risk of complete failure and potentially fracturing the mandible, osteonecrosis. If those implants are moving, we know that the bone is going to move a little bit. So you need to not put on, screw down a prosthesis, and it's going to increase that risk of failure, especially in edentulous patients.
I think, so the pathology that leads to that, a lot of times it is bruxism. So they're clenchers, so their masseters are really powerful. I mean, that's me, hello, too. But, so clenchers, the other issue, just from a patient standpoint, because I am a bruxer, is when the digital impressions are a lot easier for me, but if I do get to a point, like even when I've had 2 implants, they've had to stop and let me take breaks. Because at this point, you can tell, like, you could be open this much, but as your masseters fatigue, you start to lose whatever. So now whatever if they've been doing that and it takes a long time to get a scheme, the amount of one side might be open this much, but by the time they get to the other side, it could be collapsed to that much. So it's not uniform there.
And it's
So-
habitual clenching
Mhm.
that
It
is
is.
happening. It's like muscle memory. And so you just continue.
As I choose.
So, because that's me.
Yeah.
All right, you guys ready? We're 5 minutes past time. Just
Oh,
heads up.
shoot.
Yep,
Okay.
just a heads up.
All right.
This was great. You didn't want your face.
So basically, the edentulous patients, they have less bone very often. And then on top of that, we sometimes do a bone reduction. So really weakening the lower jaw. And so probably the deformations can happen much stronger. potentially.
Very good point.
Because most of the studies were done with actually people who had teeth impairment. Right? Huh?
Wow.
That had a much stronger jaw, which is less deformed. Yeah. So that stuff would be very interesting. There's I found the guy who wanted to do a study on that in Australia.
Are there
Can we
any
do it?
studies currently?
No.
Nobody has done something with an iCam type of technology to really measure. Most of the people that CBCT or strain testing.
Yeah, but Dr. Stevens suggested doing that. We should do a study on this if we really want to.
I think it would also be worth it to do it like
We
for
have the right
advanced
technology to
cases,
do it.
for zygotes
Yes.
and whatnot.
Yeah.
Oh, absolutely.
Or the only.
They're good.
Thank you.
Is it still rolling? Yep, it's still rolling.
Drew,
And
Get me off the record.
now we're not rolling anymore.
switch.